So we will have a moderator that I'm very, very fond of. I've worked quite deeply with Professor Kenneth Warner on reduction of tobacco use. And so let me introduce Dr. Warner. He's the Avedis Donabedian Distinguished Professor of Public Health at the University of Michigan. He also served for 5 years as the Dean of the School of Public Health. His research is focused on the economic and policy aspects of disease prevention and health promotion, with a special emphasis on tobacco and health. Professor Warner served as the senior scientific editor of the 25th anniversary Surgeon General's Report on Smoking and Health, and he is on the editorial board of 3 professional journals and chairs the board of the International Journal of Tobacco Control. He's getting embarrassed. Dr. Warner has also been cited twice by Delta Omega, the National Public Health Honorary Society for Outstanding Achievements, and he was awarded the Surgeon General's Medallion by Dr. C. Everett Koop, who is quite a guy. In 1996, he was elected to the membership of the Institute of Medicine of the National Academy of Science and to the Governing Council in 1999. All of this led to, within the Institute, serving as the chair of the Prevention Committee of the Board on Children, Youth, and Families, and co-authored the article Prevention of Mental Disorders, Substance Abuse Among Children, Youth, and Young Adults, Research Advances and Promising Interventions. In 2010, he was co-recipient of the Alton Ochsner Award relating to smoking health. So let me introduce Professor Warner.
Thank you, Bob. And if Bob looks a little bleary-eyed, it's because he told me he read the entire report last night. I did have the privilege of serving as chair of the committee that put together the report entitled Preventing Mental, Emotional, and Behavioral Disorders Among Young People, Progress and Possibilities. And if you go to the Institute of Medicine website and click on a tab that says Most Viewed Reports, you'll see that the committee's report is one of 9 that are listed in that category. I take this as an indication of the importance of this work and of this subject as it is viewed both by professionals in the field and also, I think, by the lay public. It's quite a statement, because if you look at the Institute of Medicine site and recognize the coverage that they give to issues in health and healthcare, it covers everything you can imagine. Defense, military exposure to Agent Orange, all the way up to a whole variety of healthcare issues for the nation as a whole. And this is one of the 9 most consulted reports. Now, I want to emphasize, I'm not a mental health expert. Chairs of Institute of Medicine committees are selected intentionally as people who do not come from the field of inquiry for the study. The reason for that is to lend some assurance of a sense of balance or objectivity to the proceedings of the committee, its deliberations, and the report that it produces. So as a result, being involved very intimately in this study for a long period of time afforded me an extraordinary opportunity to learn. And what I learned both fascinated me and frankly frustrated me. I don't think I need to tell this audience that mental, emotional, and behavioral disorders among young people are pervasive. You know that. But I must tell you that prior to the study, I had no sense of how pervasive nor how consequential they were. But what I also learned, and I found simultaneously both very encouraging and frustrating, is that we have cost-effective means of dealing with many of these problems and specifically with preventing them. Yet as a society, we do very little to address the preventable problems. We're penny wise and pound foolish. And as a consequence, we end up with an enormous burden of unnecessary costs, decreased productivity, crime, and most important, of course, illness and misery. In today's opening session, we're going to hear from 2 of the members of this really extraordinary Institute of Medicine committee. And while they will discuss the report, they've also been given the latitude to draw on other work, including their own work, to address the broader subject of the conference. Each of our speakers has committed to taking no more than 25 minutes for their presentation. So our intention is to have a conversation with you folks at the end of the two talks. There are a couple of microphones, which you will see there in the middle of the floor, and we ask you at the end of our second speaker's comments to please go to the microphone and ask your question or offer your comments. Our first speaker is Dr. E. Jane Costello, professor of the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. She's also co-director of the Center for Developmental Epidemiology in the Duke University Health System. Dr. Costello received her bachelor's degree and a Master of Philosophy from the London School of Economics, both in social psychology. I wanted to emphasize that because as an economist, I didn't want to have her tarred with that particular label. She has another master's degree from Oxford University and a PhD in psychology from the University of London. From 1981 to 1983, she held a postdoctoral fellowship in psychiatric epidemiology at the University of Pittsburgh. The Center for Developmental Epidemiology brings together researchers from different disciplines to advance understanding of the origins, course, and prevention of mental illness across the life course. Dr. Costello's program of empirical and theoretical work has convinced her that child psychiatric epidemiology has to incorporate developmental science if it is to carry out its mission of understanding, treating, and preventing the psychiatric disorders of childhood and adolescence. Dr. Costello is using data sets to develop a model of child psychopathology that will help integrate findings about the causes of mental illness, which she refers to as etiologic epidemiology, with a better understanding of risk factors and the options for prevention, which she calls public health epidemiology. She aims to use findings from this work to develop a set of propositions about how public health can use a primary care, primary prevention model to improve the emotional and behavioral development of children. Dr. Costello is currently directing the 8th annual wave of data collection for the Great Smoky Mountains Study, a longitudinal analysis of the development of psychiatric and substance abuse disorders and access to mental health care in a representative sample of 1,400 children and adolescents living in the southeastern United States. I ask you to please join me in welcoming Dr. Jane Costello.
Well, thank you, Ken, and thank you all for being here. I'm, as Ken said, an epidemiologist, and for those of you who are not familiar with epidemiology, it's the study of patterns of disease in time and space, and what we can learn from those patterns to help, first of all, prevent and then treat disease. And it's those patterns that I want to talk about, particularly patterns in time. Oh, conflicts, none. So in my 25 minutes here, I'm going to talk about three things. First of all, because I'm an epidemiologist, I always get rolled on first at any meeting to talk about the size of the problem. What's the prevalence? How many people are we talking about here? So I'll talk about that very briefly. And then secondly, I'll turn to the main topic of this meeting. What does going to college have to do with early depression? And from here on, I'm going to be drawing on our own data from the Great Smoky Mountains study because, frankly, there are too few studies that track individuals through time, from childhood through adolescence through early adulthood, which is what we need if we want to understand the impact of going to college on depression. And then thirdly, I'll turn to the issue of prevention. And I'll come back to this later, but to begin with, since Bill is not here to give our model of prevention, which he will discuss in much more detail later, I want to make a very basic distinction between what we call universal and targeted prevention. And for universal prevention, think about seatbelts. We don't go around saying, you're a dangerous driver, therefore you must wear a seatbelt, but you're not, so you don't need one. We make everyone wear seatbelts. We give clean water to everyone. And those are universal preventions. And then there are targeted or high-risk preventions where we look at, for example, children whose parents have just died or children whose parents have gone through a divorce, and we say these children are at high risk, and therefore we will intervene with targeted or high-risk prevention programs for them. And these universal and targeted programs tend to look very different. And so one of the themes I'll come back to at the end is, what do we know about risk for early or college-age depression, and which of those factors look as if they would be amenable to universal prevention versus targeted prevention. Okay. So a quick tour of prevalence. This is the result of a meta-analysis we did of about 25 epidemiologic studies. By epidemiologic, I mean they used the whole unselected population as their sampling frame, not just clinical cases. And the yellow blocks show the range of estimates that fall in the middle to 50%, and then the whiskers show you the estimates that go way off the middle. And for the age of interest, for this talk, the young adults, I don't have a meta-analysis, but I do have data from the National Comorbidity Study, which is about 10,000 individuals and gives us a big estimate. And as you can see, the prevalence goes up from young children to adolescent boys to adolescent girls to young adults. And by the time you get to young adults, you're talking about a point prevalence. That's epidemiological jargon for asking people how you feel now or within the last 2 or 3 months. A point prevalence of about 10%. What happens after that, well, we'll maybe address later. So that's point prevalence. If you ask people, how are you now, or how have you been in the last few months? And by the way, these are clinical cases. These are clinically depressed people. This is not just, are you feeling a little bit depressed? This is, do you have enough symptoms for long enough at enough severity to meet clinical criteria for a depressive episode? So there's another sort of prevalence, and that's cumulative prevalence. If you add up all the cases that happened up to a certain point in life, how many cases would you see there? And in order to look at cumulative prevalence, we need longitudinal data. And this is where the United States of America really lets us down. The whole system for funding research in this country makes it very, very difficult to get the kind of longitudinal data that we need to look at things like cumulative prevalence or long-term prevention. So I'm afraid I'm having to return to my own research here, which we've been doing since 1993 in an area of the western North Carolina, and the study is called the Great Smoky Mountain Study because that's where everybody in the study lives. And in this study, we've also looked at point prevalence, and as you can see, the point prevalence is not dissimilar from the estimates that we saw earlier. Rates of depression higher in girls and boys, which is one of the best-known things about depression, I think. But when you look at cumulative prevalence, you get a very different picture. I'm sorry these are not easy to read, but that's because my colleague Bill Copeland made this in some fancy program that I can't change the colors. But if you look at that, you'll see that by age 21, not 10%, but 16% of girls and about 14% of boys have had a depressive episode. And here to emphasize again, I'm talking about a clinical level depression. So lesson one to learn about depression in early life, it's not rare. Although at any one time it's not so common, if you look back over people's lives, and this is not retrospective, this isn't saying, do you remember having a depressive episode? This is people who've been studied every year, or almost every year since they were 9. Then we get these really very concerningly high rates of depression. Okay? So that's everything I'm going to tell you about prevalence. You can ask questions later on if you want to. Question number 2, how does going to college affect rates of early life clinical depression? Well, I can only find 2 studies that address this. The first one is from New Zealand, from the Donabedian longitudinal study, and they have one paper which looks at went to college versus didn't go to college, and they found no difference. So I looked at these data again in our own study, and here I made use of the longitudinal component of the data to say, if you look at people who went to college, first of all, do they differ from people who didn't go to college? But then we split it up more finely and say, what about the ones who completed college successfully? What about the ones who went to college but dropped out? And what about the ones who never went to college at all? Do we see differences in the rates of depression over time? And we have measures at 19, at 21, and at 26. And this is what it looks like. The red line are the people who never went to college. The green line are the people who successfully completed their degree. And the yellow line are the people who went to college and dropped out. And what you can see is that at 19 and 21, the people who didn't go to college are more depressed than the people who are in college at that time. So that's lesson number 1, that the problems of early adult depression are not restricted to college students. In fact, to the contrary, the problems are higher in the people who didn't go to college. However, if you fast forward to age 26 and look at them, you see something very different. The people who didn't go to college, the red line, seem to have sorted their lives out, and very few of them are depressed. The people who went to college and completed their degree have vanishingly low levels of depression. The people who are in trouble are the people who went to college but didn't complete their degree. So I think this sets up the issue of college depression in a somewhat different way. Now, this is looking forward in time, and those of you who are dealing clinically with college depression can't see that far into the future. You don't know which of your students are going to drop out. You don't know which of them are going to get depressed. So let's look at this in a bit more detail. Well, first of all, is this a gender-related issue? And the answer is basically no. You see the same identical pattern in males and females. It's just more on a larger scale in females because, as we said before, depression is much more of a risk for girls. But basically the pattern is the same, and the boys are, or the young men, should I say, are as likely to be depressed if they drop out of college. So, first set of conclusions, that prevalence differs between males and females, but the pattern's the same. Secondly, that depression is extremely low in this sample, and remember this is just my sample, 1,400 kids, fairly normal representative sample, but still only one sample. Depression is extremely low in the group who graduated from college within an appropriate time. It was higher in those not attending college, but it fell by age 26. And the real problem was in those who attended college at 19 to 21, but did not complete a degree by age 26. So, can we figure this out or get a bit deeper into the question? Was it failure to complete, or was it something about the length of time they were there, that they weren't there long enough? So, to answer this, we looked at the people who completed a 2-year degree in a community college or somewhere, and those who completed a 4-year degree. And I hope you can see. So these are the people who completed a 4-year degree we saw before, and the green line are the ones who completed a 2-year degree, and basically no difference, very low rates of depression in both those groups. And the pattern in the ones who failed to complete a degree, whether it was a 2-year or a 4-year degree, are the same, very high. So if we look at the issue of, is it length of time in college or is it completing a degree, the issue is failure to complete. So, and that just says that the rates were even higher in those who completed only 1 to 2 years of a college course versus those who completed 2 to 4 years. So what's going on here, and what should we do about it? Well, there are 2 ways we could think about this, and here's where epidemiological data fails us. This is an observational study. We didn't do an intervention. We weren't able to artificially, at random, assign people to complete or not complete. We couldn't just say to a random sum, all right, you're done, out of here, and see whether it affected their rates of depression. So this is an observational study, so we can only use it to generate ideas and hypotheses, which someone else is going to have to test. But here are the 2 hypotheses. That it would reduce rates of young adult depression if we helped young people, first of all, to attend college, because if you go back to the slide, you'll see that the ones who, the red line, the ones who don't attend college are also at increased risk for depression. So hypothesis 1, follow the Obama doctrine, help everybody to attend college and to complete college, and that will reduce depression. And then, as you know, a subsection of this, maybe some of the people who failed to complete a 4-year degree would happily have completed a 2-year degree, and that too would reduce rates of depression. On the other hand, hypothesis B, the default hypothesis, is that going to college has nothing to do with depression. That if you encourage people to attend, then people who would formerly have been non-attenders will bring their depression to college with them and increase rates of depression in college. That encouraging college dropouts to complete a degree would just increase the rate of depression in completers. That it wouldn't buy you anything, that these 2 are not related to one another. I think that the fact that the 2-year completers had as little depression as the 4-year completers is suggestive that this was in some way related, but I can't prove this. And so, question to you in the audience, what should we do to test these hypotheses? What experiments could we do? Can you think of any? We'll discuss that maybe in the question time. So point number 3 was, what are the causes and what are the implications for prevention? And these 2 go hand in hand. Obviously, you're not going to prevent something if your intervention isn't in some way linked to the causes of the phenomenon. Giving roses to everybody won't prevent depression if absence of roses, lack of roses, is not causally related to depression. So, again, we turn to our own data here. And the first thing, an obvious thing to look at is an early history of depression. Here we're talking about depression between 9, when our study started, and 16, which covered our adolescent phase, is a history of depression early in life associated with a risk of, first of all, of non-completion at college, and secondly, of later depression. And here, for the males and females, I've divided them up into whether they had depression between 9 and 16 or they didn't. And as you can see, these are the early depressed groups, males and females. If a person had a history of depressive episode between 9 and 16, they were more likely not to go to college, that's the red line. They were less likely to complete college, that's the green bar, and they were in the case of the females, they were more likely to drop out. In the case of the males, interestingly, they weren't more likely to drop out because they were more likely not to go to college in the first place. But they were less likely to complete. So, from the point of view of prevention, the message from this is that those who were depressed before the age of 16 were less likely to go to college, less likely to complete, and this suggests that we need to think about treatment and prevention of earlier childhood depressions if we want to make an impact on college attendance and success. If you then go on and say, but does early depression affect success in college? Does it affect whether people completed or whether they had later depressions? And I've just used the age 26 data here. The age 1921 data looks roughly the same. People with a history of childhood depression were more likely to drop out and more likely not to go to college. And much more likely, sorry, I'm telling you the wrong thing. People who had a history of early depression, if they dropped out, were much more likely to have an episode of depression. This shows rates of depression. And if they didn't go to college, they were more likely to have an episode of depression than the people who had no history of depression. No effect on the ones who went to college. So even somehow or other, either selection for college or whatever happens to you in college seems to protect even the ones who had a childhood history of depression. But in the other two groups, the ones who didn't go to college or the ones who dropped out, risk of depression was particularly high in the ones who failed. So, I've just said that. So what about other risk factors? That's epidemiological jargon, risk factor. We don't want to ascribe a causal relationship between bad things that happen early in life and later on events, so we call them risk factors because it's a nice wishy-washy term that doesn't imply causality. Okay, so we went back into our data and we collect a lot of information about things that have happened from pregnancy onwards. And these were the factors that predicted college-age depression. And they range across the age span. So the first ones had to do with pregnancy. The children whom the mother said she didn't welcome this pregnancy, and this is her information, we didn't ask the dads, but she said the father didn't welcome this pregnancy either. 20 years later, these kids are at increased risk of depression. A history of sexual abuse or physical abuse, and this is a lifetime history of sexual or physical abuse, also increase the risk of early adult depression. Current material hardship, and material hardship covers both income and other resources. A biological history of a psychiatric disorder. This is the mother's lifetime psychiatric history based on a psychiatric interview. If either the mother or the father, biological parents, had a history of using mental health services, either for psychiatric disorders or for drug abuse, that increased the risk. And then amongst recent events, a recent breakup with a close friend was a risk factor. So you look at this group of risk factors and you say, what are the implications for prevention? And here I come back to the distinction I made earlier between universal and targeted prevention. Which of these would be amenable to a universal intervention, a seatbelt kind of intervention, and which of them would be more amenable to a high-risk intervention? And I'm not going to answer this. I think that this is something that we need to discuss as a group. But how would you find out if someone was at risk of being an unwelcome fetus? It's fairly easy to identify people who are in material hardship, but is the best way to intervene just with the poor people or with everybody? What do we do about preventing sexual and physical abuse? What do we do about preventing breakup with best friend? Do we have a universal prevention to stop people from quarreling with their best friends? Or do we have a targeted program to say, if somebody's had a really painful breakup with a best friend, maybe Bill needs to go in and help them? What about children with a family history of psychiatric disorder or drug abuse? Which is the best way to prevent depression following these? This is something we need to discuss, I think. My conclusion, for what it's worth, is that we need both universal and high-risk measures. But in terms of bringing this back to a discussion of college and depression, I think we need to think very carefully about what universities can do to monitor and prevent the academic failure, which seems to be a major risk factor, at least in this sample. Colleges have to maintain their standards, obviously, otherwise they would be a waste of public and private resources. The standards are sacrosanct. But given that, how can colleges address this issue that it's the failures who seem to be at particular risk? Thank you very much.
Thank you, Jane. Our second speaker is Dr. Williams Beardsley. Dr. Beardsley is Director of the Baer Prevention Initiatives, Chairman Emeritus of the Department of Psychiatry at Children's Hospital in Boston, and Gardner Monk's Professor of Child Psychiatry at Harvard Medical School. He's a senior scientist at the Judge Baker Children's Center in Boston. Dr. Beardsley received his bachelor's degree from Haverford College and his MD from Case Western Reserve University. He trained in general psychiatry at Massachusetts General Hospital and in child psychiatry and psychiatric research at Children's Hospital. He's the author of over 175 papers and chapters and 2 books. Dr. Beardsley has directed the highly successful Prevention Intervention Project. This is a 10-year study of response to public health preventive interventions for families facing depression. He's also the principal investigator of the Boston site of a 4-site trial that has demonstrated that it is possible to actually prevent episodes of major depression in high-risk youngsters. Dr. Beardsley serves on the Carter Center Task Force on Mental Health and the Board of Mental Health America. He has received a long list of honors and awards, most recently in 2005, the Human Rights Award from the Massachusetts Department of Mental Health. Please join me in welcoming Bill Beardsley.
Thank you, Ken, for that overly kind introduction, and Jane for a wonderful presentation. It's great to be here. I think this is a tremendously important conference and a very exciting time to be working in this field because we have much that we can do and evidence that we can base our programs on. I also want to commend John Greedon and the Depression Center here. It's a national model that really has made a huge difference in people's lives and has helped focus attention on the problem of depression in adults. I'm going to talk broadly about some conceptual and findings from the IOM report, then a little bit about the specific question of depression prevention. I'm not going to try to link these to what kinds of programs would be best in colleges, because I think that's a subject really for discussion. So I think one piece, I'm a physician, I work at a children's hospital in Boston, and as a clinician, if someone comes to see me, my question is, what can I do right now today for this person with this illness that will quickly ameliorate the symptoms? If I'm thinking in a preventionist point of view, I ask the question, what does this child need 1, 3, and 5 years down the line, and what systems involving the child, the family, the school, the healthcare system, and the larger society need to be in place in order to guarantee the greatest likelihood of success for all. Mental health and physical health are inseparable. Successful prevention is inherently interdisciplinary and very often moves from one sector to another. Effective interventions in schools can have a large impact on people later in life either not becoming addicted to substances or not getting in trouble with the law. I think Jane has very compellingly made the point, and we made the point in the report, that mental, emotional, and behavioral disorders are developmental. Coordinated community-level systems are needed to support young people, and in that sense, we might say the University of Michigan is a community and is trying to think about how to develop a community-wide response to depression. And a developmental perspective is key. I'll highlight one thing that Jane emphasized, which is right after puberty, the rates of depression go up very dramatically, both in young women and young men. Hence, many of us have tried to position interventions right before that period. Now, in the report, we tried to think about broadly medicine and identified that on the left-hand side is treatment, on the right-hand side are the aspects of health promotion and prevention. I had served on the Institute of Medicine's Committee on the Prevention of Mental Illness in 1994. At that point, we did not have a part of the pie that was promotion because we didn't know enough about the evidence to be certain that it should be included. Now we think it should. And then the three kinds of prevention: universal prevention, that's what's good for all people or all children, so immunizations or high-quality schools. Selective preventions are those that are delivered to groups at high risk, such as children of depressed parents, such as children who've suffered parental bereavement. And indicated preventions are what Jane means by targeted. That is, those interventions are delivered to people who are already manifesting symptoms. Now, I think another key issue, and I'm a physician, I'm trained in the diagnosis to recognize problems and treat them, but in thinking about prevention, we have to equally study strengths and resiliences. So in the IOM report, this was our definition of health. Health promotion aims to enhance individuals' ability to achieve developmentally appropriate tasks, developmental competence, and have a sense of mastery in doing that, and strengthens people's ability to deal with adversity. So this then is, again, a kind of large conceptual map about the kinds of preventions. Across the top are different developmental epochs, and then coming down are different kinds of preventions that are appropriate at different points. We certainly think that pregnancy prevention, or at least unwanted pregnancy prevention, is needed. Certainly there's overwhelming evidence that the environment for the fetus in utero is important. We need excellent prenatal care. And then in infancy and early childhood, there's lots of evidence for high-risk families of both nurse home visitation programs, such as David Old's, and high-quality center-based care, such as Head Start and Early Head Start. As we move into childhood, certainly high-quality academic interventions make a difference. Certainly also parent skills training and some other kinds of social skills training have a pretty strong evidence base. As children move into adolescence, we do have evidence about the prevention of depression. We have some evidence from Bill McFarland's group and Tom McGlashan's group about the prevention of full-blown first episode psychosis by picking up on early warning signs and aggressively treating. across the bottom, and this is an important issue for all of us, there are three lines that essentially characterize all these developmental epochs. Prevention focused on specific family adversities, bereavement, divorce, parental psychopathology, community interventions, interventions that strengthen communities and resources, and policy interventions, that is, interventions such as those that Ken has been involved in to try to increase smoking cessation, decrease tobacco use. And I would say, just from a policy point of view, as one example, in this country right now, we are pretty well able to provide care for very poor infants up until a year or two of life under Medicaid. But we are completely unable to provide funding for care for their mothers. That makes no sense. And all we know about development is that the early years are the most important. If you get things right during those years, many other things can be prevented. So that's a policy issue that we need to consider. Now, most of us work from a risk factor model, trying to identify risk factors which occur well before the onset of disorder, also protective factors, and position interventions to either diminish risk factors, increase protective factors, or both. There are multi-year efforts described in the report on substance use, conduct disorder, antisocial behavior, aggression, and child maltreatment that show some powerful effects. There are indications that adolescent depression can be reduced, and interventions that target family adversities, such as depression or bereavement, have a strong evidence base. And I mentioned the work of Bill McFarland and schizophrenia. Looking across the evidence, most of us look for meta-analyses, that is, analyses that combine a number of different studies and come up with more robust findings. There's evidence that school violence prevention programs, when well done rigorously, can reduce aggressive problems by a quarter to a third. Social and emotional learning programs have improved academic outcomes. And there's promising but limited benefit cost or cost benefit information. We need more of that. Certainly the best evidence comes from the savings delivering programs early in childhood, but one of the programs I'll describe later in depression prevention has a very promising cost-benefit analysis as well. Just to give you one idea of what these programs look like, David Hawkins and Rico Catalano at the Social Science Development Group in Seattle delivered an intervention which involved teachers, students, and parents in 5th and 6th grade in the public schools in Seattle, and a multivariate effect across all 16 primary outcomes were found with better educational and emotional attainment, mental health, and sexual health by age 27. So prevention is possible. This is a particularly good group in Seattle, but it makes the point that we really can do a lot to lessen the burden of illness and ensure movement toward healthy development. Again, another thing that many of us are interested in is we may target an intervention to a particular area, but it may have broader effects. Examples with multiple outcomes, positive outcomes, are parenting programs, comprehensive early education, interventions for divorce, and school-based programs. So we should be thinking about that, particularly when we're talking about children and adolescents. Now, Ken highlighted, and I think a central issue in the field is taking programs that have been demonstrated to have efficacy in efficacy trials and effectiveness trials and moving them to scale. And there's a lot of interest in that right now. I think in '94 we had some good efficacy studies. Now we have some pretty good effectiveness studies and are beginning to have some idea about how to move things to scale, but we have a long way to go. And there's sort of three strategies in taking programs to scale. First, to take a program and try to do it pretty much the way the intervention developers did it, using the same criteria and so on. A second is really adapting or changing to meet cultural needs, different age groups, different presenting problems. And all of these need to be evaluated. And the third is to join with communities with general principles about prevention and design programs specifically for them. There's evidence that all three of these approaches are useful. And I think in thinking about colleges, and particularly here at Michigan, which is such a leader, do you think that the programs that are here could be simply replicated at other colleges, or do you think colleges should more from the ground up develop and adapt their own settings, their own student bodies to the principles that seem to characterize good health services? So the recommendations of the report, well, let me go back to one other factor. As a scientist, I was quite skeptical about a lot of the progress in neuroscience for a while because it seemed like it was enormously expensive to do the studies and the yield was relatively small. I've completely changed about that. I think that the neuroscience work is really about developmental plasticity, is really about, in the best sense of the word, preventive intervention, and we strongly looked at the neuroscience evidence and found that it very much supported the idea of preventive interventions. Since we now have epigenetic phenomenon, that is, phenomenon that can be transmitted across generations without altering genes, but without, it's even more important to pay attention to this. And we would say that the basic science of prevention is the science of understanding child development, and we recommended linking genetics and neuroscience research with prevention research. That's something John Greedon is very committed to and a leader in. Now, we had two sets of recommendations. The first is that we need to spend much more time and effort on disseminating effective preventive interventions, that is, putting knowledge into practice, and we need to continue the course of rigorous research. You could say, well, you know, this guy's an academic doctor, he's going to talk about research. Well, true, but the reason we need to continue the research is it's the only way we can be sure about that what we're doing is the best possible approach. And the field of preventive intervention is filled in the past with people who were charismatic leaders and said, we must do this, we must do that, without an evidence base. That's true in the substance abuse field, it's true in the mental hygiene movement, and so the evidence is what really must guide us, and I think Jane's talk gives an illustration of how evidence can be brought to bear on important questions, and certainly we need far more evidence. Now, in thinking broadly from a public health point of view, this was one other major finding of our report. One factor lurks in the background of every discussion of the risks for mental, emotional, and behavioral disorders and antisocial behavior: poverty. Although not the focus of this report, there is evidence that changes in social policy that reduce exposures to these risks are at least as important for preventing mental, emotional, and behavioral disorders in young people as other preventive interventions. We are persuaded that the future mental health of the nation depends crucially on how collectively the costly legacy of poverty is dealt with. So again, from a public health point of view, we need to be very much concerned about poverty. The recommendations make healthy mental, emotional, and behavioral development a national priority, establish public prevention goals. The White House should establish ongoing multi-agency strategic planning mechanisms. They've done that, and states and communities should develop network systems. So that's a broad overview. The take-home message is there's lots of science to back up the idea that we should think about prevention. There's lots of evidence that you can try specific, you can base your work on specific preventions, and you need to measure what you do. Now, coming just to depression for a moment, this is just a standard public health slide about what the risks for depression are. And here on this side are specific risks. That is, these risks lead to depression in those at risk, such as extensive family history, especially parents, prior history of depression, depressogenic cognitive style, and bereavement. And remember that risks don't necessarily talk about mechanisms. So in families where there's increased risk, people share genes, they share environments, and depression appears to impair parenting, and also people who are depressed have more negative life events. All of those things probably operate together in leading to higher rates of depression in the children of depressed parents. These are risks for many disorders: trauma, poverty, social isolation, job loss, unemployment, family breakup, loss of communication, dislocation, immigration, and historical trauma. I became aware of historical trauma by working with the Blackfeet Nation in an early Head Start project in Browning, Montana, but clearly there are groups that have been systematically discriminated against and bear a costly legacy because of that. All of the factors on the right there are specific studies that show increased rates of depression as a result. So Steve Gilman and colleagues at the School of Public Health at Harvard have shown that children who grow up in poverty have increased rates of depression throughout their lives, even if they move out of poverty. We need to address poverty, not just because of depression, but because of the many other things. But speaking as a scientist, if I'm concerned about depression, I have to think about poverty. And although Jane did not mention it, she participated in a wonderful experiment, which is that Native Americans in the Great Smoky Mountain study were overrepresented in the epidemiologic sampling. At a certain point in the course of the study, a successful casino was established, and the incomes of the families, the Native American families, went up quite significantly, and those who were in the study and not Native Americans were a natural comparison group. And the mental health of both the children and the parents improved, and it was dose-related. That is, the younger the children, the longer they were exposed to the increased standard of living, the better they did. So again, we need to be bold in thinking about the kinds of things we need to do to prevent illness. Now, just again, depression prevention examples. I think you all have my handouts at the end. I have references to all of these. But Ricardo Munoz, who served with me in '94 on the IOM prevention report, also served on the report that we're talking about now, the one that Ken and Tom chaired. He's argued very compellingly that major depression can be prevented. There's a meta-analysis from Kuipers that shows that if we look at randomized controlled depression prevention trials in adults, evidence suggests that approximately 22% of major depressive episodes can be prevented. I'm a psychiatrist, and I often deal with illnesses for which we have neither very good treatments or very good preventions. That's absolutely not true with depression. We have excellent treatments, and we're beginning to have good preventions. I think a second area, particularly in talking about youth, is delivering preventions to people who are highly symptomatic. Hurwitz and Garber have done a meta-analysis, I have the reference in the references, and shows strong support for small to medium effect sizes in reducing depressive symptoms, which very often are the precursor to depressive episodes. Probably the best known program of this is Marty Seligman's program at Penn, and using a cognitive behavioral approach in schools has shown dramatic reductions in depressive symptoms in a variety of different contexts. And the reference, the lead author is Brownwasser, is a meta-analysis of Seligman's work. Now, I was allowed to go beyond the IOM report, and I'm going to finish a couple of remarks and then talk about the other IOM report, which was on depression in parenting. But I want to make one other point, which is that depression prevention is often an outcome of another intervention. Here at Michigan, Rick Price and colleagues developed the JOBS program. In the 80s, it was a program to rapidly intervene with auto workers who were losing their jobs, help them develop skills and become reemployed. It was quite successful. And in looking at the 2-year outcomes, there were actually many fewer cases of depression in the group who received the jobs retraining than the group who didn't. Erwin Sandler and colleagues have done an excellent preventive intervention for families in which one parent dies during childhood. That's a not uncommon phenomenon. About 4% of children have a parent die during their childhoods. In delivering the intervention and comparing it to usual care, Sandler and colleagues found substantially better mental health and educational outcomes in the group that received the intervention. When they looked at why that happened, the mediating variable in that study was that the parents who got the intervention were more effective parents. And in Early Head Start, which is a program, high quality center-based program for kids 0 to 3, we looked, and Early Head Start have dramatically high rates of depression, as high as 50% in some studies. They showed that as the children gradually benefited from Early Head Start, as they got better and stronger, more developmentally capable, the parents' depression receded. So each of these programs helps individuals and families accomplish age-appropriate developmental tasks and embeds prevention and treatment in larger systems that foster these. So one thing to think about with college students is depression prevention programs for college students should not only address symptoms, but should also have as their goal helping students stay in and succeed in school. And that very much follows Jane's observation about the costs of dropping out of school. Now, this is the IOM report on depression in parenting in children. It came out a few months after the prevention report. The prevention report had a strong section on depression. This was sort of then a subset of that work. And just briefly, depression in parents leads to sustained individual, family, and societal costs. It appears that depression in parents can interfere with parenting quality, put children at risk for poor health and development. At least 15.6 million children live with an adult who had a major depression in the past year. And we arrived at this number, 15.6, not by finding in the literature. What was striking is, for a public health problem of major proportions, there's very little written about parental depression. We were able to derive this number by working with Ron Kessler and the National Comorbidity Study and did our own independent analysis. That's a large representative epidemiologic sample that has looked at diagnosis and functioning in adults. Now, in terms of the evidence, a variety of safe and effective tools exist for treating adults with elevated symptoms or major depression. There are a variety of strategies to deliver these. But again, almost never in studies of adults do people describe who's a parent, do they look at the outcome on parent functioning or on child outcomes. So we think there's a lot of work to be done there, and in particular because we have some very promising treatments and preventions, so that there's a great deal we can offer. And in terms of treatment, it's very clear that having choice makes a large difference, and that treatments, tools, and strategies to deliver treatments should be flexible, efficient, inexpensive, and above all acceptable to the participants in a wide variety of community and clinical settings. The keynote speaker yesterday, I think, was talking about how to deliver access to treatment, access to care in a way that's acceptable to the Cornell community. And I think in general that's an important principle. And I think there is also a strong knowledge base for preventive interventions. We've not taken in this country many of those preventive interventions to scale, but they mostly involve making sure that the parents get good treatment, providing help with parenting, and using a two-generational approach. Some of them also directly involve children. And just very briefly, Family Talk is the intervention my team and I devised in Boston. It involved working with families in taking a history, doing some psychoeducation, seeing the children, sitting with the parents until they felt ready to have a family meeting to talk to their kids about depression and how the family would overcome it. Then holding the family meeting and then following them. We compared this to the usual standard public health intervention, which is having a boring, aging white male give lectures. I gave the lectures. So when we looked at the outcomes, we found sustained gains in family functioning, reductions in depressive symptoms, and sustained gains in family communication around depression. We found much greater effects in the talk intervention condition than in the lecture condition. But the lecture condition turned out to be a strong intervention, and we found that these were sustained. I'll talk a little bit more about this, but one of the trials that's been most widely cited in terms of prevention of depression is a foresight replication of Greg Clark's preventive intervention using a cognitive behavioral approach. That's led by Judy Garber. Bruce Compass, who was on the committee, devised an elegant intervention where he puts together 4 families, has some meetings with the parents, some meetings with the kids, works on social skills as well as psychoeducation, and has shown quite dramatic results in a large trial. I mentioned the Irwin Sandler work on bereavement. I mentioned that early Head Start and Head Start have quite high rates of depression. Frank Putnam in Cincinnati has added mental health component to nurse home visitation. Again, high rates of depression in these mothers, very good effects. Carolyn Webster Stratton's The Incredible Years is a social skills training program for parents, been widely used. And Ricardo Munoz has developed a intervention for postpartum moms that has a reasonable evidence base. Across these prevention strategies, there's a strong theoretical orientation with an emphasis on cognitive changes. There's an orientation to strength building and enhancement of protective factors. There are manualized approaches with careful training and strategies for selections of indicated groups at high risk. And I see that I'm just about out of time, so I'm going to do two things. This is the Clark intervention. It shows that there were significant effects in the prevention of depression, the lower line, the blue, and at 15 months, the rates of depression were 30% in the experimental group, 9% in the other group. The replication of that with Judy Garber's group, again, 20% versus 30%. So we can prevent depression, and then I have just implications, include health promotion, consider selective preventive interventions, use multiple means of entry, evaluate with continuous improvement, and use strength-based approaches. Finally, two unanswered questions. Should the families of college students be considered? Why be concerned about earlier experiences? And what constitutes an excellent college depression program integrated with a fully functional national health insurance program with an emphasis on health promotion and disease prevention? And in the slides, you'll see our vision for the future from the IOM. So let me just get this off.
Thank you, Bill. There will be a quiz immediately following the break on those last 10 slides. We can't possibly see you out there. I hope we're going to get some light coming up. Good. If anybody would like to have address the speakers with questions or comments, there are a couple of mics right there, please.
Hi, Adam Kaplan from Johns Hopkins. I'm actually a neuropsychiatrist, not an epidemiologist, but I have an epidemiologic question for Drs. Costello and Beardsley. Thank you very much for a wonderful overview. Dr. Costello, it seems to me, to the uneducated, non-epidemiological psychiatrist, that your data highly supports at least a plausible hypothesis that it's not college or attendance at college that's affecting the depression, but it's the depression that's affecting whether or not people are going to college or staying in college. So it seems like one testable hypothesis, you had asked a question, one testable hypothesis would be if you start intervening more in screening for depression, you keep kids in college more. Because it seems like the magnitude could be enormous, that this could be one of the most common reasons for people failing. And Dr. Beardsley, question for you is, and I love the emphasis on the parents, of course, the irony is that by the time the kids are at college, it's sort of hard, it's perhaps a little too late. But to intervene, but I love the emphasis there. And I guess the question I have for you is, we see all these risk factors. Is there a way to quantitate them? Because there are so many risk factors that you named, but you came back in the end, and I think in the end, for a targeted intervention, kids of parents are clearly at increased risk just from genetics. And if we could target and intervene in treating the parents as you suggested, that to me makes sense. But do you have ways of ascertaining, is this the big risk factor? Is this the big elephant in the room or not? So.
I think the question about quantifying it is we can estimate the magnitude of certain kinds of risk. I want to emphasize what I said before, that when we're talking about something like parental depression, we're talking about multiple factors being bundled into that, genes, environment, and so forth. But most people would say, at least in childhood and adolescence, bereavement, parental depression are two of the most potent risk factors for depression, and that's why they've received the attention they have.
So coming back to the issue of causality and direction and effect, absolutely, it's a question, an empirical question. How would we test it? I think there are two ways. One is to screen kids carefully for depression when they apply for college and refuse admission to everybody who has a history of depression, and compare, which would be 20 to 30% of the population. And the alternative would be screen kids carefully for a history of depression at admission to college, and then focus a major prevention program on helping them to avoid failure in college. And I think it would be a really interesting way to go. It raises ethical questions, if you like. You know, do universities have the right to explore family history of mental illness in evaluating applications? Do they have a right to explore individual applicants' history of mental illness in evaluating applications? And I'd like to hear your thoughts about that.
So my name is Melvin McInnes. I'm here at the University of Michigan Depression Center. I study the genetics of mood disorders. I'm stymied by what truly is changing. Our base observation is that there is an increase in the rate of depression. No? Because you showed a line there that there was an increase in the rates of depression.
That was showing cumulative rates of depression in the same youth, following them over time. So if they had an episode at age 9, they would be on the line for age 9. If they had an first episode at 15, that would add to the cumulative rate.
Okay.
That's very different from an increase over time. And we have a paper I can give you a reference to, which is a meta-analysis of all the studies of early depression from 1965, which is the earliest we can go, up to 2000, and there's no increase in rates of childhood and adolescent depression.
Okay, but depression overall, so this is young adult depression in the college grade. So you're saying the depression, the rate of depression in society has remained stable?
The rate has remained the same for as long as we have evidence for it. And we can't go back before the 1960s, because that was when we first had standardized measures that enabled us to estimate.
So the cohort effect of the perceived increase in the rate of depression,
that's a media belief. It's not okay. Based on any evidence.
So your thesis would be then that what is actually changing?
Well,
because you showed one of the risk factors you showed was, for example, the rate of unwanted pregnancies, or that was associated with. Is that? Do you believe that to be changing, or what is it that? About what exactly are you proposing that's changing? Or not? Or is there anything changing? Maybe I'm talking up the well.
I don't think I was saying that anything is changing.
Because I saw a graph that you showed the increase in
okay.
the.
Supposing you were interested in flu, the prevalence of flu.
Okay.
At age 9, 5% of the population have had flu. At age 10, another 5% have had flu, so that makes 10%. At age 15, another 5% have flu, so that makes 15%.
Thank you.
That was a cumulative graph.
Okay, thank you.
I believe there's somebody over here. It's really hard for us to see.
Okay. I actually have a question and a comment. The comment relating, Jane, to your question that you threw out just a second ago about screening college applicants is that personally I'd be very opposed to that. But I do think that once they're accepted and they're filling out all the rest of their medical forms and so forth, that would be a very appropriate time to screen, so that right from the beginning, before they even set foot in a classroom, there can be some support, intervention, and normalizing and all that kind of stuff that would be helpful, I think. I'm sorry, go ahead.
Just to be clear, the U.S. Preventive Services Task Force has recommended yearly screening for depression for all adults. So that's the standard.
And
second,
children.
let me finish. We recommended very strongly that the only kind of screening to consider is voluntary screening. So first of all, people have the right to be screened or not. And secondly, that as is true in all situations, there needs to be absolute confidentiality about the results of screening or recommendations for treatment. That would be true at the college student level. It would also be true in dealing with other groups.
What about screening children?
Can I, just
yeah,
before you go on to your next, I would also add to that I think it's most unethical to screen people for a condition if you don't have the services in place to treat them. I think that's absolutely unethical. But if you have, and it looks as if you do here, then I think there's something to be considered there, so long as it's voluntary.
Yeah. What about, this is actually, since there's no one else, oh, there are. Okay. I'd love to know your thoughts about annual screening for children as well with depression, because you said specifically adults. But the other question I had was, again, I think it was something one of you said, I'm sorry, I've forgotten, about interventions, and very quickly mentioned prenatal interventions, which took me by surprise. I mean, other than diet and that sort of thing, what prenatal interventions are there?
The most obvious one is that every child is a welcome child.
Thank you.
Just to follow up on that, in Massachusetts, we require pediatricians to do voluntary screening for mental health issues at every annual visit, at once a year. So that's a part of the situation. I think the pregnancy issues. There are not a lot of interventions that have specifically targeted mental health prevention during pregnancy, but there are an increasingly large number of women who've had depressions and may still be actively in treatment for these depressions who become pregnant. And there is accumulating evidence that there are ways to successfully help these mothers manage their pregnancies and avoid depression and have healthy children. So there it's really a question of fine-tuning the treatment during the pregnancy.
Thank
Thank you.
you. Question over here, please.
Hello, Dr. Beardsley. This is a question for you, and my name is Dr. Aditi Sengupta, and I am a member of the Harvard Medical School Postgraduate Association. The question is, you mentioned about the education, economic attainment, mental and sexual attainment of an individual by 27 years of age, which gives the maximum potential later in their lives. But if there is a deviation from in any of these aspects, the person, is he or she susceptible to depression at a later age? And as you again mentioned that there should be a screening process by the task force. So if on screening at a later age they are found to have depression, is there a single modifiable environmental factor which will help them to regain back to their position which they have been before? And this is a question for Dr. Costello as well. So is there any modifiable environmental factor in later age, if depression is detected, that can change the person's lifestyle by changing the lifestyle, or anything which is very important which can bring back that person to normal functioning? Thanks.
Well, can I just say, first of all, that screening is not diagnosis, and I think we have to be very careful when we use the word screening, that we don't make the assumption that the person has a clinically significant illness simply because they've scored something on a screening questionnaire. So a high score on a screen must be followed by a clinical evaluation if we're to say that somebody has or doesn't have a disorder. The main things are enough sleep, decent food, and lots of exercise, as far as I know.
That means an overall lifestyle change, right, from what the person is going through?
One of the most remarkable things about prevention, and in a way one of the most encouraging things, is how far the major preventive interventions are the same for all diseases, all chronic diseases. It's the same for diabetes and for cardiovascular diseases it is for mental illness. Decent diet, decent exercise, plenty of sleep, and then start worrying about whatever the additional factors may be.
And living in the context of healthy relationships. I think that's the other, healthy relationships are the other very powerful force universally.
Thank you.
Thank you.
Here at the CAPS office at the University of Michigan. One of the things we're wrestling with as an agency is how to reach more of the students here at the University of Michigan. We see about 3,400 students a year, which sounds like a lot, but we have 42,000 students here on campus. So we're experimenting with a lot more didactic programming, a lot more workshops. We do a lot of outreach on campus. We're still not reaching enough students effectively. So Dr. Beardsley, I was hoping you could talk a little bit more about some of the intervention programs for which you said had efficacy evidence, and how you think we might be able to borrow from some of those learnings here at the University of Michigan or other large campuses to help us reach more of our students who we know are struggling with depression but aren't coming in for counseling services.
It's a very good question, and let me first draw something from Ken's field about tobacco prevention, tobacco cessation. We did a study of public health interventions in the '94 IOM report, and one of the things that was clear is that in the anti-smoking campaigns in those days, there was a synergy across using different modes to heighten public awareness. So public health campaigns, media campaigns, delivery of prevention, preventive interventions for smoking in doctors' offices, delivery in schools, et cetera. I think with first thinking about the campus and reaching more students, I would say try to use multiple modes of entry, as many different ones as possible. The internet, clearly student unions, clearly health services. We just finished a study for the Urban Institute about depression in home visiting programs, and we did focus groups in 3 cities on 5-day visits, and it was amazing what these mothers could tell us about what kinds of services they would go for and what not. So I think another thing is really running focus groups with different kinds of college students here at Michigan and say what would make it possible for you either to come for services or for you to help a friend who's having a hard time come for services. So I think that's the, it's many different strategies, each of them hopefully culturally competent and culturally humble to try to get people into the evidence-based either treatment or prevention.
I'm Laurie Davidson. Until recently managed campus programs at the Suicide Prevention Resource Center funded by SAMHSA. And I have a plug and a comment and a question. And the plug is the last gentleman's question will be answered in great depth in my presentation with my colleague Karen Moses right after this plenary. And for those of you who saw Dr. Beardsley slide by the recommendations for how the IOM report applies on college campuses, we have a lot for you in that session. I also want to point out that this is the comment part, that the important thing to remember, I think the most important thing I took away from the IOM report was the importance of health promotion in addition to prevention, and that it was a public health approach, and that people in the mental health field needed to learn from public health colleagues how to do that. And I think this question of reaching students falls back into the trap of how do we find the people who need treatment and get them treatment. In the 20 or 30 year campaign about tobacco, you mentioned a lot of awareness campaigns, but what also was happening were public policies that restricted the use of tobacco, that increased the price of tobacco. And I think we struggle in mental health to find those environmental. I came from working in college alcohol prevention. I know what the environment is that abets high-risk alcohol use, but what exactly is the environment that could be changed? And I think there are a couple of elements that speak to social connection, et cetera, and there's a presentation later today on that as well. And then my question is for Dr. Costello. In addition to the depression data, did you look at suicidal ideation, suicide attempts, and suicide as well, and were there any findings you'd be able to share here briefly?
Yes, we have looked at suicide and suicidal prevention. I think the biggest take-home message there, and this I hope doesn't apply very much to a college campus, is the interaction between violence and suicide. We've had, of our 1,400 kids, 23 have died in the course of this study, which seems an awful lot to me. But when I look at the causes of death, it's awfully hard to distinguish between accident, homicide, and suicide. There's this nexus of violence involved in these deaths that I find very disturbing. I really hope that college campuses are different from this, but that's been our finding.
Couldn't resist
I think we're running out of time, but first I want to thank the panelists. You're great, and I think you're calling attention to a problem that all of us need to take home to our campuses. Prevention should be our mantra for the next decade. And the points that I wanted to make are what I heard are, one, early depression is bad. What I didn't hear, and I want to amplify for everybody, is there are data out there that early treatment and attainment of wellness are good. It actually is a predictive variable in preventing future recurrences, chronicity, etc. So our challenge that all of you pointed out are how do we put together screening and confidentiality and getting people in, and that I think is the focus of much of this conference. And being an integrator, it's in my genes. I think I want to make a point from yesterday. I had the opportunity, I wish I missed the first part, but I sat in on the wonderful session on technological aids and really strategies. And I think what we all probably need to do is recognize the population that we're dealing with. Social networking, phones, tools that people have access to are all going to be part of how we take those first 2 points, screening and getting people into treatment, getting them well and keeping them well. And I think that if we can push that message, we'll have a better success in getting at this population, the ones between 15, 24, 25. And I wanted to point out just one thing. Sleep, for example, is a real precipitant. We grew up, I did, being a psychiatrist and kind of a neuroscientist. I think I grew up in the era of studying sleep actually with electroencephalography. There now are tools available that are like wristwatches. You wear them on your wrist, actigraphs. They actually count every 8 degrees of movement or so. They measure light, and they're pretty good tracings for, do we have sleep problems? Maybe it'll get to the point where everybody who comes in has voluntary screening, has sleep issues. We know that sleep accentuates and precipitates depression. Maybe we can get them to buy an actigraph in addition to a cell phone. Maybe they can learn to be their own monitors of wellness. Maybe they know that when they travel across time zones, that's something to pay attention to. And that actually leads to all of the things that I think we need to push. And it was also emphasized yesterday, care management and self-learning. And that's a key principle in prevention. And there are toolkits available. But I just wanted to thank all of you for bringing all of us a bit more sophisticated into the IOM world. Thank you.
Well, thank you. And I just want to emphasize one thing you're saying, and highlight it, which is that we need integrative systems that provide both prevention and treatment, and people can move flexibly back and forth between them. And certainly, I didn't say, but I've been involved in a number of countrywide programs in Europe for children of the mentally ill in Holland, Finland, Sweden, and Norway, and that's an integral part of their National Health Service. It's an integral part of what they do, and I think that's the way we need to think about re-engineering our systems. I was also in the meeting on media yesterday in the afternoon, and it was terrific, and it did suggest a number of different avenues that we can explore that we haven't fully yet.
We have one more question.
I guess it's not exactly a question, it's a response to one of the questions that you posed about involvement of parents for college-age students. I'm a graduate student at Northwestern University, and I was actually an undergraduate here at U of M, as well as an academic peer advisor. And I guess I just wanted to, from my observations for what it's worth, that even people who are coming from fairly stable homes at this period in their lives have a lot of difficulty communicating with parents as they become young adults and as they make that transition as a family. And I do think that offering both counseling on a family sort of level, as well as just information for parents on how to communicate through some very difficult issues, whether it's coming out with sexual orientation or financial issues with their students or other just family value issues, would be very beneficial for a lot of students.
So I think it's a very thoughtful comment. One of the studies we did in this large family talk study was we devised a young adult interview and interviewed, these kids were enrolled when they were 8 to 15. Many of them were in their early 20s when they ended the study. And it was an interview about what it's like to grow up in a home with a depressed parent and then leave and go to college or go into the military or go into the workforce or whatever. And I was, in looking those over, it was very clear that the parents' depression loomed large in the consciousness of these individuals, many of whom did well. And I posed the question about parents not at all. It's obvious that there are clear ways in which young people need to separate and go to college and be free of the home environment, and there are certain legal protections and others that we all support. I just mean that making sense of one's experience in a family is a continuous process that doesn't stop when one goes to Michigan or Duke or any other school. And we need to recognize that as we try to position our resources. The second thing is, the only kind of communication with parents, as far as I'm concerned, from students or people who treat those students, is one in which there's full permission given by the student. But then I would say parents can be enormous allies in the treatment of people with depression, just as they can for younger age people. And there's lots and lots of evidence. When the family is involved positively, the treatments have much better outcomes.
This is reminding me of when my daughter called me at the age of 20 and said, "Mother, I have decided to forgive you." Finally, I think it's important to emphasize that depression doesn't exist in a vacuum, that it's associated with drug abuse, with violence, with all sorts of other dangers, and any prevention program, campus-wide prevention program, I think needs to be very broadly focused on all these things. The plus side of that is the same preventions seem to work across a very wide range of conditions.
Do you want to make any concluding remarks?
Since you give me the opportunity, one thing that has sort of been in my craw the entire time since we did this report, and I will emphasize that I was really delighted to see the one session upcoming at 10:45 that I will attend, and that's the whole implementation issue. And there are a couple of things that need to be said about it. It is not simply a matter that we have these effective programs and we haven't figured out how to get them implemented in reality. There's a very big difference in many fields between efficacy and effectiveness. So some of these programs may work very well when they're run by the experts who are really devoted to them and have the resources. And then the question is, how good are they in everyday practice? And we haven't talked a lot about that here today, but I think that's an issue we should be concerned with. And I would simply like to echo the theme that if you can come up with environmental or policy type interventions, you're going to have a much more wide reach and probably a far greater cost effectiveness. That doesn't mean that those interventions are more effective at the individual level, but it means when you look at the reach that they have for the dollars spent, you're going to have a bigger aggregate impact for whatever your expenditure may be. I don't know what those are in this field, and with all due respect to Bill, his work is absolutely fabulous. When we talk about the individual family interventions, that's a tough thing to figure out how to accomplish on a widespread basis, and I would challenge all of us to try to think of what we can do in a cost-effective manner to achieve what we know is possible as a result of the study. Thank you.
Thank you all. Thank you, Dr. Beardsley, Dr. Costello, Dr. Warner. As we conclude this morning's session, I want to remind all of you of the concurrent sessions. There's a 15-minute break. The concurrent sessions are all on the 4th floor.